Hello, everybody. Thanks so much for joining today. Thanks for joining our MASLD MASH Community Network. We'll be presenting pharmacotherapy. My name is Melissa Franco. I'm a PA at the University of Miami. I've been doing hepatology for quite some years. And so let's start. Please use this QR code to record your attendance for this meeting, please. So let's start talking about pharmacotherapy. So as we could see in the pie chart, we are going to discuss current treatments for this metabolic management. As we could see in the pie chart, we need to focus on controlling obesity, reducing cardiovascular risk, and targeting MASH. So how do we control obesity? Well, we want to aim for weight loss in our patients, and weight loss could be achieved either through lifestyle, through diet and exercise. Now, what type of diet? The Mediterranean diet. I encourage all my patients to follow the Mediterranean diet because it has the best evidence across medical societies to help with fatty liver and also to engage in physical activity. If patients are totally sedentary, I start by telling them to walk every day for 30 minutes, but at least they should aim for 150 minutes of moderate intensity exercise per week or 75 minutes of vigorous intensity exercise. And how much weight are they supposed to lose? Ideally, they should lose 7 to 10% of the body weight to help with reversal of that fat and also reversal of fibrosis. Weight loss medications could also help. Medications like orlistat or phentermine or Contrave could help with weight loss. Bariatric surgery or endoscopic procedures could help, like the gastric balloon or duodenal mucosal resurfacing. Bariatric surgery like sleeve gastrectomy or bypass could help with weight loss. And medications such as GLP receptor agonists, because these medications will affect, they will make them feel fuller and it will help with weight loss. Now, in patients that have more advanced liver disease, make sure that we choose medications appropriately. Now, let's move on to reducing cardiovascular risk. So this is very important, and I stress this to every patient, that the main cause of death in these patients is cardiovascular disease. So we have to make sure that diabetes, high blood pressure, high cholesterol are under control, because the main cause of death is cardiovascular disease, heart attacks, stroke. So we want to make sure that all these cardiometabolic risk factors are managed. Diabetes, ideally, if patients could be on GLP-1 receptor agonists, that would be great because it will help with weight loss. Hypertension needs to be controlled. Dyslipidemia, very important. And I also discuss this with my patients. Cholesterol medications are safe, are actually beneficial in this group of patients because they have underlying fatty liver. This is not going to cause any increased risk for drug-induced liver injury from statin medications. Even patients with cirrhosis, with well-compensated cirrhosis, they can take these medications. So it's very important that we stress that to patients and to primary care physicians because they will have a benefit. And we have to target NASH and fibrosis in the liver directly and we can offer a liver-directed treatment. We're going to discuss vitamin E, Pioglitazone, and Resmetirom as treatments. It's not advancing. Yeah. So GLP receptor agonist. These medications, so after we eat, there are some hormones that are released by the gut to help in lowering blood glucose. We have endogenous GLP-1s that are secreted as a result of after eating foods. So these GLP-1 will stimulate glucose-dependent insulin secretion. They will suppress glucagon, which is a hormone that leads to stimulates hepatic gluconeogenesis. This will delay gastric emptying, so patients will feel full. And the medication is going to directly act on the hypothalamus to promote satiety and reduce energy intake. So patients will feel fuller, they will eat less, and this will help with weight loss. These are analogs of the gut-derived incretin hormone that I discussed before, and this medication will help improve glucose level and aid in weight loss. What is the role of GLP receptor agonists in hepatology practices? So this medication, semaglutide, was studied in a trial called the Essence trial that studied semaglutide 2.4 milligrams once weekly on MASH patients with stage 2 and 3 fibrosis. There was a total of about 800 patients, and this medication successfully met both primary histological endpoints at 72 weeks because it showed MASH resolution without worsening of fibrosis, and it showed significant improvement in fibrosis. So consider administering or recommending GLP-1s for patients that have fatty liver, that are overweight, and give higher priority to those patients that have MASH and fibrosis. However, in your lean MASH patients, which we could see patients that are not obese, not overweight, and that have fatty liver, then we shouldn't offer this medication, but we should focus more on exercise and diet for this group of patients. And how do these medications affect GI providers? So because this delays gastric emptying, this is going to increase the risk for aspiration on anesthesia. So if patients are scheduled to have any endoscopic procedure like endoscopy, colonoscopy, and they have taken the medication within a week of the procedures, you can consider canceling the procedure. Let's talk about vitamin E. So before we start, I want to tell you about the PIVENS trial. So the PIVENS trial was a multinational randomized double-blind placebo-controlled trial that was done on MASH patients with biopsy-proven MASH. And it wanted to evaluate the efficacy of vitamin E, Actos versus placebo. So this trial lasted 96 weeks, I believe. And what it showed, and the primary endpoint was histological improvement of MASH. Vitamin E achieved this primary endpoint because it helped improvement in liver histology. Actos didn't meet the primary endpoint in improving histology in MASH patients, but it had some benefits in cardiovascular events, but neither one improved fibrosis. So vitamin E was studied, and it showed it was effective in about 43% of patients in this trial, but it had some limitations because not all patients responded and wasn't used in diabetic patients. Based on the guidelines, based on the American Association for the Study of Liver Disease guidelines, you can use vitamin E. It may improve NASH in non-diabetic patients. However, the EASL, the European Association for the Study of Liver Disease, does not recommend it because it has limited efficacy on fibrosis and it has some potential risks. So what potential risk? Increased risk of bleeding and also prostate cancer. So patients that have underlying coagulopathies or patients that have an increased risk for hemorrhagic events should not be using this medication in the long term. Pioglitazone was administered at a dose of 30 to 45 milligrams per day in MASH patients with or without 2 diabetes. And like I discussed before, it didn't meet primary endpoints, but it improved, but it showed positive effects on cardiovascular, it decreased cardiovascular events like MIs and strokes. However, there were some safety considerations because there are some associated risks with these medications, such as the weight gain. Patients tend to retain fluid, so it can lead to edema and congestive heart failure, increased risk for bone fracture, especially in women, and increased risk of bladder cancer. Resmetirom. So Resmetirom is the only medication as of right now that was approved last year in March of 2024 in conjunction with diet and exercise to treat non-cirrhotic MASH patients. That means that this medication is indicated for patients that have MASH, that are non-cirrhotics, that don't have mild disease, that they are they have stage 2 and stage 3. If patients have cirrhosis, then you cannot use this medication. As of right now, it's not approved. And this is a thyroid hormone receptor beta agonist that binds to these specific receptors in the liver and treats this inflammation and fibrosis. So before we dive deep into resmetirom, and we have to understand the physiological relationship between thyroid and the liver. So as we could see, T3 and T4 production is regulated by the hypothalamic pituitary axis through TSH. And this hormone has an effect on the liver metabolism, on the brain, on the heart, through thyroid hormone receptors. Thyroid hormone has different receptors, as we could see here, alpha and beta. Alpha receptors are located in the brain and the heart. Beta receptors are located in the liver. So what thyroid hormone does is that it helps with lipid and glucose metabolism in the liver. This medication upregulates genes in charge of triglyceride fatty acid oxidation and decreases accumulation of triglycerides. As we could see here, TSH will decrease hepatic lipase and decrease H and G CoA reductase, leading to increase in lipogenesis and hypertriglyceridemia and hypercholesterolemia. MAESTRO-NASH trial. So this is an ongoing phase 3 randomized controlled trial of resmetirom in NASH with liver fibrosis. This was a trial that was studied in adults with biopsy-proven NASH with stage 1, 2, and 3. There were a total of 966 patients that were randomized to 3 arms. One arm had 80 milligrams, the other arm had 100 milligrams, and the other arm had placebo. And it had 2 primary endpoints at week 52. One of the endpoints was NASH resolution by improving NAFLD activity score to more than or equal than 2 points without worsening of fibrosis. And the other point was improvement or reduction in fibrosis by at least 1 stage. Safety. Side effects. The most commonly seen side effects were diarrhea and nausea, as we could see, compared to placebo when resmetirom 80 and 100 milligrams were administered. And the incidence of adverse serious events was similar across trial groups. The primary endpoints. So as we could see in the graph, the arm that with resmetirom, the patients that received resmetirom 80 milligrams and 100 milligrams showed NASH resolution compared to placebo with no worsening of fibrosis. And the patients that received resmetirom in 80 and 100 milligrams showed fibrosis improvement compared to placebo by more than or equal than 1 stage without worsening of the NAFLD activity score. So there are some practical considerations when managing these patients. We have to take into account that the ideal patients for treatments are those adults with non-cirrhotic MASH, Patients that have stage 2 or 3 fibrosis. So remember, there are different stages of fibrosis that go from 0 to 4, 0, 1, 2, 3, 4, 4 being cirrhosis. So this medication is indicated to treat F2 or F3 fibrosis, not mild, not cirrhosis. And this medication is approved in conjunction with diet and exercise. So it's very important that we document this in our notes, because I've encountered issues with the approval. If we don't document that, sometimes medication won't be approved. So we have to indicate that this medication, we have counseled our patient that exercise and diet was discussed, and the patient is willing to try this, and it will help with the approval. There are some drug-to-drug interactions, as we could see on the left-hand side. There are some medications to avoid because there are strong 2C8 inhibitors, meaning that it will increase the plasma concentration of resmetirom. These medications include Fibrosis, cyclosporine, darunavir, clarithromycin, flunamide. And there are other medications that are tolerated with resmetirom, but we have to reduce the dose of resmetirom to about 60 milligrams. These are clopidogrel, befarasirox, mefeprim. Befarasirox is an iron-chelating agent, so the dose will need to be reduced. There are some other medications on the right side that add an increased risk of exposure due to resmetirom. Among these are Pioglitazone, amotridine, paclitaxel. And in terms of cholesterol medication, statin use, just keep in mind maximum dose of pravastatin, atorvastatin would be 40 milligrams, and maximum dose of simvastatin and rosuvastatin is 20 milligrams. What about duration of treatment and monitoring? So there is still an ongoing evaluation because this trial is still ongoing. We'll need to, so usually patients that have been started on this medication, we usually assess with non-invasive tests after a year. You could do 6 months or after a year. And we check liver enzymes, we check fibrosis, either with FibroScan or MRI, proton density fat fraction, or ELF. And if you see an improvement of liver enzymes along with improvement in the steatosis by 30%, equal to 30% or more, then you can continue this medication. If you also see improvement in FibroScan by dropping of the liver stiffness measurement by 30% or more, then these patients can continue. If there is no improvement, you can consider continuing the medication. If there is worsening of fibrosis, then you can stop. However, there is still discussion about, and expert panels are currently working on this to give us more information about periodicity of testing at this time. And there are some questions that still remain because a lot of patients want this medication, and some of them meet criteria. And I have come across some patients that where insurances don't approve the medication. So we still have some patients that their insurance won't approve this medication. There is not insurance coverage. We still need to assess for staging at 6 months or a year. I usually do it in a year. And of course, we need to monitor lab tests after starting the medications, check for liver enzymes. And we need also advice on treatment recommendations and when to discontinue treatment, because when we start patients, we usually tell them that this medication is, as of right now, it's going to be lifelong or for a very long time, but we still, this is not going to be a short course of treatment. At least we need to wait a year and see what happens and continue treatment. And in the future, there will be other options and other agents that are currently being under study at this time. and MASH will likely have more treatment options in the future. But as of right now, this is the only medication that we have. So thank you so much for attending this meeting. If you want more education, more disease state education, you can visit the GAPO MASLD MASH Community Network to view MASH disease state education and Rezdiffra promotional program. You can scan this QR code. Thank you so much for joining. Do you have any questions?